Okay, so let's go to our second case. And it's a 75-year-old woman, hypertension, hyperlipidemia. So she's presenting to your office with chest pain to mild exertion. But I'm just going to do it here, fairly quick. And what I would like to show you afterwards is, the FFRct. So we're going to do like, the same, MIP. We can, kind of window it, so we can see we have a higher width, over here, so more shades of gray. And as we go down, we can see left main, you have the proximal LAD, and it looks like, something here that might be severe. And as you go down, there might be something else, over here. And then the distal runoff is fine. And the LAD, it kind of wraps around the apex, okay? So it's a big LAD. As we go down, as we go back, here, we check the circ. So the circ is over here. And the circ is a non-dominant circ, also doesn't have much going on over there. The RCA has a lot of calcifications at the ostium, okay? These Ostial RCA lesions, they can be very tricky in the cath lab because you're engaging, sometimes you don't see it. But as you go down, you can see at the groove, over here, and this is important because Dr. Winkler, he's our chair, for the cardiac CT boards, and some of us, here, we make questions and everything. Not that this question will be on the board, but some of the things that we test, sometimes is we show like, this image here, and we ask, okay, what's the dominance? And here you can see on the groove that the RCA is pretty big, and we don't have any left circ here. So we know just by this picture that's going to be like a right dominant, system, right? So as we go down here, you have like a PDA, and you have like, the posterior lateral branches here, and there's nothing much going on the RCA aside from that ostial lesion, right? Now, I'm going to go to the thin slices. And so I have like, my LAD. So the LAD looks like there's something here, right? There's like some lesion over here. If I go down to this area, it looks pretty severe, right? Right? And then we have like, the RCA as well. And the RCA, we have to locate the RCA here. I can just click it. And the RCA, our concern is about the ostial RCA. So this is the ostium, right? So the ostium looks like, we can see the lumen there. So it looks more kind of a moderate, kind of disease. So we have like a severe stenosis at the distal LAD, at the mid LAD. And we have a, that osteo RCA that looks moderate, over here. So let's go back to our slides. So here, this is what the road map, show us. So it's pretty good. This is AI. This is a little concerning because, it pick up, that severe lesion over here and moderate, RCA. So so we are kind of in agreement, with the machine, and it can see like the reconstructions it gives us, pretty similar to what we got, right, on the LAD. And this is the FFRct. Okay, so again, this case, the patient had a severe stenosis at the LAD. You could argue that, okay, let's just send this patient to the cath lab, right? However, he also has a moderate disease on the RCA. So the reason why we did, the FFRct here, it was not for the LAD because I knew it's probably going to be severe. And you can see, the red, you can see the big translational pressure drops like 0.71. But it would be important for the cath lab, folks, to know if also the RCA would be hemodynamically significant. And the RCA looks fine, right? So that's another, so this nuance, on the FFR, it's important, for you guys to have, again, if it's clear like a CTO, you're not going to send it just for the CTO. But if the patient has other like moderate lesions, that you are uncertain if this is hemodynamically significant or not, you may benefit, from having the FFR, okay? So that's a big take-home point here. So this is a cath, and you can see the LAD here, pretty tight, right? The RCA looks fine. And this is, after the cross lesion, the inflated balloon, and boom, the patient is fine, and the patient is now chest pain free. So what we predicted before, the high PPG, high translesional pressure gradient, we normalize that, and the patient is fine, okay? So this is our impression, right? So this case was a CAT-RADS 4A, right, because of the severe lesion. It was a P3, so there's severe amount of plaque, the Cal score is 569. HRP, because, that lesion over here, it's a soft plaque. It has positive remodeling. It also has a little bit of enhancement. It might not be easy for you guys to see it here, but this enhancement on the periphery, that's what they call napkin ring sign. It's another marker, for high risk, plaque, okay? So that's an HRP. So we sent you FFRct analysis. It was FFRct positive. So we can add I plus here, right? So I plus because FFRct is a functional testing, right? Also, in some places, we don't do it frequently here in the US, maybe a few places in Europe, they do it more. But we can also do like perfusion, CT perfusion, and if CT perfusion is positive, we also put an I plus. So all of this letter soup, by some of our colleagues, Dr. Ricardo Curry, who came up with CAT-RADS, fellow Brazilian, you're going to be tested on this, okay? So you need to understand what it means, and because some of these, have a lot of prognostic significance.